Thank you, Mr. Piyush. I welcome each and everyone who has joined us today to the ICS ILD webinar series, and which is the brainchild of the brilliant Dr. Mita Nene, Dr. Sandeep Salvi, and Dr. Rajadhar, of course, the education director for ICS. And I take great privilege and honor in inviting Dr. Rajadhar today to moderate this session, which is the Hypersensitivity Pneumonitis webinar. We all know Dr. Rajadhar is the beloved teacher, the most beloved teacher of all young pulmonologists, young and elderly, I must say, because Dr. Rajadhar is equally loved by all and most befittingly and lovingly called Dronacharya, as Sir has received the Dronacharya reward, award also. And Sir is the director of pulmonology at 𝐃𝐽 Birla Hospital, Kolkata. And a special thank you to Dr. Rajadhar for bringing HERMS to India. It was a dream for me, and I was so happy that I got to be in the first batch at Kolkata. Thank you, sir. A special thanks again. And now I invite Dr. Rajadhar to please take over this session.
Thank you very much, Kira. Thank you for those kind words. And it's bright people like yourself and a lot of others around the country which are actually taking the specialty forward. So a big thank you to the Indian Chest Society for coming up with this concept of the ILD module. Today, our topic for discussion, as you heard, is about hypersensitivity pneumonitis. You know that the ILD India registry, which got published about 5 years ago, thought that chronic hypersensitivity pneumonitis was the most common cause of interstitial lung diseases in India, with more than 47% of patients in India having HP or chronic HP as the etiology for interstitial lung disease. We also know that the incidence of hypersensitivity pneumonitis in the various parts of the country, the north, the south, the east, and the west, is somewhat different. The triggers which cause HP are different, which is why on your panel today, the speakers, the panelists are all from various corners of the country. And we'll try and give you a flavor of this disease, how it is globally, what the management strategies are. But more importantly, we'll talk to you about hypersensitivity pneumonitis from an Indian perspective. That's what's on the annual. A big thank you to Dr. Amita Nene, whose brainchild, hard work has actually come up with this and more modules. So watch out for this space. We are doing ILD. We'll be doing airways disease in a few days. You will see an ICU module. So that's a lot on the anvil from the Indian Chest Society and a lot of people within the Indian Chest Society, led by our Training and Education Initiatives Chair, Dr. Amita Nene. You will see a lot in the space of webinars and physical meetings in the next few months. The first talk that we have today is from Dr. Bhavin Jhankaria. Now, Dr. Jhankaria does not merit any introduction. The chest radiologist, our go-to chest radiologist, even for me, is Dr. Bhavin Jhankaria. He works at Picture This, which is his own institute, Imaging and Beyond. He's spoken at innumerable meetings, chest meetings, and he's always the first person that we think of when we invite anyone to talk about any aspect of radiology, chest radiology. So that's the first talk today. Imaging in hypersensitivity pneumonitis is what you will hear Dr. Jhankaria speak on. The next talk we have is from Dr. Murli Mohan. Again, it's not for no reason that he's called the Einstein of pulmonology in India. So Dr. B.V. Murli Mohan is a senior consultant and the academic director of the Department of Internal Medicine and Pulmonology, Narayana Health, the Mazumdar Shaw Medical Center, Bangalore. So what I know as Narayan Rudale, that's where he is and has been for a long time. His areas of passion, his areas of special interest are pulmonary hypertension and interstitial lung disease, multiple awards, honors, etc. I won't take you through all this, but things that you might not know is his ability as a quizzer. He's a queen quizzer. He's helped me in setting up the Indian Chest Society quizzes in the past. And there are other areas of interest. His writing is his forte. He's multiply talented. And that's going to be Dr. Murli Mohan with the second talk. Post this, we'll have a panel discussion, which will be for 45 minutes, for which I'll have an elite panel. And I said the elite panel covers all parts of the country, and I'll introduce them in a bit once we come to the panel. So the first talk starts off over to Dr. Bhavin Jhankaria speaking about imaging in HP. A big thank you to the huge audience who logged in today. I know we've reached about 1,000 logins and we're waiting for many more. I hope you have your time's worth in listening to this webinar today. Thank you very much.
Hi, this is Dr. Bhavin Jhankaria, and today my topic is hypersensitivity pneumonitis. So I'd like to thank Cipla for giving me this opportunity, and I'll spend the next about 18 to 19 minutes talking about hypersensitivity pneumonitis. And the plan today will be to talk about the definition, the diagnosis and patterns, and progression and progressive pulmonary fibrosis. So HP is an immune-mediated disease that manifests as interstitial lung disease in susceptible individuals after exposure to an identified or unidentified factor. And all of these things are important both from the radiology and the treatment and diagnostic perspective. So the old classification of HP was acute, subacute, chronic, inflammatory, chronic, etc. Today we have a simpler classification which is more radiologic, dividing this into non-fibrotic and fibrotic. Though on occasion we would still land up calling something chronic, especially if it's non-fibrotic but lasting over many months or years. And so chronicity is determined by the number of months that the patient has had the disease, and that's usually more than 6 months. Now, in 2020, we had a white paper on the diagnosis and management of HP, which then tried to differentiate these diagnoses into typical, compatible with, indeterminate, etc. But it's extremely confusing and not really relevant in practice, unlike, let's say, the 4-column or the 4-bucket classification that we have for fibrosing ILD. So how do we diagnose non-fibrotic hypersensitivity pneumonitis? We look at the 3 components of HP, the parenchymal, where we see ground glass and mosaic attenuation, the small airways component, where we see ill-defined centrilobular nodules and air trapping, and the distribution in both craniocaudal and axial, in which case it would be diffuse in both directions. And I'll show you examples of that. So let's look at ground glass and mosaic attenuation. So this 38 years old, exposed to mold in the house, has all of these findings. So just focus on these, right? So we see these ill-defined areas of ground glass from the apex to the base. You can see, therefore, that it's diffuse craniocaudally and it's diffuse axially, going from the hilum to the periphery. There is mosaic attenuation predominantly because of patchy air trapping. So we have the small airways component and we have the parenchymal component as well. The expiratory images show us the air trapping extremely well and gives us better confidence in making the diagnosis. Now, many people are often confused with the mosaic pattern. That is, when you see something like this, where you have patchy ground glass, some uninvolved areas or some lucent areas, how do we differentiate these from areas of constrictive bronchiolitis or chronic thromboembolic pulmonary hypertension? And this is a patient with hypersensitivity pneumonitis. And I will just show this in brief. If you want, you can try and take a screenshot of this. But you basically have to check the vessels in the black areas and then from there figure out whether there is air trapping or not, and then take it from there. So in constrictive bronchiolitis, in this patient, you'll see that the lucent areas do not have as many vessels as the white areas. Plus, you have on the expiratory images air trapping. And the normal lung, which here is in any case normal, shows increased density, and it shows a gradient from non-dependent to dependent. In CTEPH, again, we have fewer vessels in the lucent areas, but you'll realize that on the expiratory images, the blackness remains as it is, the whiteness remains as it is. But you see that in the white areas where there is hyperemia, because these are the only perfused lung segments, we see these fat vessels within the white areas. And that is what will give us a clue that this is CTEPH. Obviously, the MPA will be dilated. And in HP, we have a combination. We have ground glass. We also have these areas of air trapping. But we know that there is parenchymal disease, and that allows us to make the diagnosis of interstitial lung disease. The other non-fibrotic pattern is that of centrilobular or bronchocentric nodules. And this is a 36-year-old lady, wife of the previous patient. And you can see here that we see these subtle, ill-defined centrilobular nodules, again, carpeting the lung. So diffuse distribution craniocaudally, diffuse distribution axially. We also see some areas of air trapping, which you would on the expiratory images. And the ground glass is really just coalescence of all of these ill-defined centrilobular nodules. Now, when you look at these magnified, you can see these non-branching, ill-defined centrilobular nodules, which is the initial airway component where you have immune-mediated granulomas that develop in a patient who has exposure to a specific antigen. When we see nodules or small nodules in the lungs, again, you can take a screenshot of this. You have to figure out where these fit in. And here we have, without additional findings, non-random, centrilobular, non-branching. And there we have just one diagnosis, and that is hypersensitivity pneumonitis. And I've taken a magnified view, compared that with normal lung to show you these non-branching centrilobular nodules, and compared it to the tree in bud, where you have branching centrilobular nodules that you get with inflammatory or infectious bronchiolitis. And this is the difference between the two radiologically. So now let's move on to fibrotic hypersensitivity pneumonitis, where we get the various constituents of fibrosis, irregular linear opacities, coarse reticulation with lung distortion, traction, bronchiectasis, and honeycombing. We may still see the components of small airways disease here. So that's the parenchymal, that's the small airways. And the distribution, in this case, when it's fibrotic, will be axial, and you may have craniocaudal equal, but you do get mid-lung predominant, and often the lower lobe is spared. So that, when we get, again, allows us to confidently say that it's a non-IPF pattern and likely fibrotic HP. Two signs that help us, the triple density and hexagonal. This is the triple density sign, where we see areas of ground glass, we see normal lung, and we see lucent lung, all within the same segment. And I can show you here as well, right? Ground glass or increased opacity or reticular opacities. You can see lucent lung, and here you can see normal lung. And when we see the triple density sign, which was earlier called the head cheese sign, it is specific, or rather gives us confidence that we're dealing with fibrotic HP. Though now over the years, we've also seen this with other entities like fibrotic sarcoid, etc. The hexagonal pattern is when we have perilobular disease, and this typically coincides with the triple density sign. But you'll find, and I've tried to show this here, that your reticular opacities follow this perilobular pattern here, as you can see marked with the red lines. And you will also see usually a triple density. So you see these reticular opacities and ground glass, you see lucent lung, and here you see normal lung. So that's how you can put these together, and this increases the confidence for fibrotic HP. So let's look at one case which allows us a better understanding of the whole process. This is a 65-year-old non-smoker, had progressive breathlessness over many, many years. And you can see here, I'm going from the base to the apex. So we have traction bronchiectasis here. We have reticular opacities and architectural lung distortion. As we go up, we realize that there is an upper and mid-zone predominance. In the upper lobes, we have bronchocentric fibrosis. We also have some subpleural fibrosis. We have an axial distribution from the hilum to the periphery. We also have ill-defined centrilobular nodules. And this is the entire spectrum. So if I were to show 3 representative images, here are the reticular opacities, there's traction bronchiectasis. We had an axial distribution that I've already shown, but you can see it better also on the coronal images, the bronchocentric fibrosis in the upper lobes here, and you see those ill-defined centrilobular nodules. Now, if you look at that 4-bucket classification of fibrosing ILDs, you will find that this fits into consistent with non-IPF. Now, to understand this, we should just revise our definitions of typical and probable UIP. Typical UIP is when we have reticular opacities, honeycombing with traction bronchiectasis, subpleural basal predominance, and nothing else. Probable UIP is the same findings, reticular opacities, traction bronchiectasis, subpleural basal predominance, but there is no honeycombing. And when we see both of these, then we can go back and we would say that these are suggestive of IPF. But when we see a fibrosing ILD, so we know this is a fibrosing ILD because we have reticular opacities and traction bronchiectasis. But we have additional findings. We have an axial distribution. We have upper and mid-zone predominance. We have ill-defined centrilobular nodules. We even have a little bit of ground glass. So we know that this is not your typical probable UIP and IPF. This is a non-UIP, non-IPF pattern, and therefore would fit into either fibrotic HP or chronic pulmonary sarcoid. And then we'd have to differentiate one from the other, though the findings here are more suggestive of fibrotic HP. But she had multiple scans from 2011. And if you look at the first scan in 2011-2012, you see that this is a non-fibrotic HP, similar to that second non-fibrotic case I showed you, with ill-defined centrilobular nodules coalescing into areas of ground glass. From the apex to the base, it's the same distribution. There is the same axial distribution, and this is classic non-fibrotic HP, right? So you can see those ill-defined centrilobular nodules and some areas of lobular air trapping in the lower lobes. So now there is no confusion. If you put these together, you can see how a classic non-fibrotic HP morphed into a fibrotic HP 12 years later, right? And that is why old scans matter. So often the patients don't bring the old scans. When we try to tell them, they often say that their physician said it's not required. I think everything matters in patients with diffuse lung diseases. And often we say that old scans are like gold, because when this patient presented in 2023, we were a little lost. And then when we looked at all the old scans, everything was so obvious. These findings also meet the criteria for progressive pulmonary fibrosis. Again, a white paper of which came out in 2022, headed by Dr. Raghu. And here we have a list of all the radiology findings that tell us when something is PPF. This is another patient proven to have fibrotic HP who's clearly progressed in 6 years from 2016 to 2022. So let's revise these fibrosis patterns in HP, and I've shown you parenchymal small airways and distribution. Here is a 58 years old with a 10 years history of dyspnea, where we see a pattern that is more of a triple density, but in the upper lobes we see architectural distortion and reticular opacities, not much of traction bronchiectasis and honeycombing. So we have some fibrosis findings, some small airways findings, and the patient has an axial distribution and almost similar diffuse craniocaudal. On the other hand, here we have another patient who has honeycombing in the lower lobes, has traction bronchiectasis, also has ill-defined centrilobular nodules here. And you can see all of these findings which tell us for sure that this fits into fibrotic hypersensitivity pneumonitis. So that was the aim today in this short presentation, to discuss the definition, the diagnosis and patterns, and progression and progressive pulmonary fibrosis. So to repeat, we know it's an immune-mediated condition, starts as immune complex granulomas and then can progress to fibrosis. We have non-fibrotic and fibrotic patterns. Non-fibrotic characterized by ground glass, ill-defined centrilobular nodules and specific distribution patterns. And fibrotic also having signs of fibrosis, reticular opacity is coarse, architectural distortion, traction bronchiectasis, honeycombing, and then distribution patterns which would tell us this is not UIP IPF, and so then we would think of fibrotic HP. Remember, old scans matter, and we must understand the concept of progressive pulmonary fibrosis. Before I end, a few things. I did this Thoracic Thursdays session in the last quarter, and there are 12 lectures here which are all free to view and cover a whole bunch of conditions in chest radiology for those of you who might want to see this. And if you would like to, since I post regularly, you can follow my WhatsApp channel. You can screenshot this. And a little promotion for my new book called Atmasvast, the Science and Art of Aging Healthfully, which is available on Amazon. And thank you so much for listening to me. Thank you for this opportunity. And I'm sorry I can't be present physically as well as to take questions, but I hope you have a great meeting. Take care. Bye-bye.
Thank you so much, Bhavin. You absolutely rock it as always. And we wish we could have you physically, but I'm sure that's going to happen in the not so distant future. So without much ado, the Einstein of respiratory medicine, our very own Dr. Murli Mohan for the second talk. Over to you, Dr. Murli Mohan.
Good evening. I'm Dr. B.V. Murli Mohan. I work at the Narayan Hridayalaya in Bangalore, and I'm going to be talking today to you on hypersensitivity pneumonitis, the diagnosis and management. You've already had an excellent talk by Dr. Bhavin Jankaria on the radiology, which is one of the key components, but let's do a deep dive into the other aspects of the management and the diagnosis of hypersensitivity pneumonitis. Before I start, let me thank Dr. Raja Dhar, Dr. Amita Nene, and the Indian Chest Society for inviting me to give this talk. Let's start with the definition of hypersensitivity pneumonitis. As you can see, that's a bit of a tongue twister, so I'm going to call it HP from now on. HP is a complex, immunologically mediated form of interstitial lung disease. It occurs in susceptible individuals, and it results from repeated inhalation and sensitization to a large variety of inciting environmental and occupational organic and inorganic dust, though it's predominantly organic dust that causes this problem. What is not HP is it's not atopic, and you can't really call it cryptogenic because there is an identifiable antigen or certainly some antigen that is inciting the problem. What we must exclude before we make a diagnosis of HP are drug reactions that can produce very similar radiologic and histologic pictures. These can be sometimes described on the histopathology as ILD with granulomas, but we must exclude these drug reactions. If you look at the interstitial lung disease classification, the most recent classification looks at the idiopathic and other varieties, but HP belongs to the group which are exposure related, and that's the red box that you are seeing there. When you look at the kind of antigen sources often associated with occupations that trigger off HP, you can see, I'm not even going to go into this, but you can see it involves bacteria of various kinds, including actinomycetes, fungi like aspergillus, atypical mycobacteria like MAC and others. You have various different fungi like Alternaria and Mucor species and so on. But also, one of the most common features are other organic antigens and animal proteins, bird proteins, figuring right at the top, and these will include avian feathers and their droppings. But there are also a few inorganic antigens that can precipitate HP. Isocyanates, for example, which are used often in the paint industry, but also pyrethrum, which is a component of insect sprays and powders. And this is sometimes referred to as pesticide lung. And I've always wondered, when we use mosquito coils and so on, some of them contain pyrethrum and pyrethroids, and whether this could underlie some of the cases of HP where we have no definite diagnosis to make. How common is this problem? What percentage of ILD is due to HP? It's very variable. If you look at the United States, as little as 2% of ILDs are described as being due to HP, while in the ILD India registry it went up to 47%. Europe, geographically between the US and India, is also, in terms of HP between Europe and India, reports between 4 and 15% of ILD being due to HP. Clearly there are occupational issues, there are environmental exposures, but clearly also geographical location and genetic host risk factors play a role and may explain some of the differences. The highest prevalence in these patients is noted in the 5th or 6th decade of life, so between 40 and 60. And the annual incidence of HP in the United States, which has the best figures, is approximately 30 per 100,000 persons. But something that's fairly clear is HP is becoming more frequent. If you look at the National Center for Health Statistics of the United States, they report an increase in HP mortality from 0.09 per million between 1980 to 2002, and now it has risen to 0.29 per million. This is for residents in the United States aged 15 years or older. But let's look at more local data. I've already mentioned the United States data, that's in the top left pie chart. Two large studies from India. Sajal Dhuria presented a paper where he compared data from the ILD India registry and their own data from PGI Chandigarh, which you must recall is a very large referral center, but at the same time is also a center which is a single center. So it's a mixture of wide referral base, but also with a particular interest in sarcoid. And they report something like a 10.7% of HP, while our own study, we looked at more than 400 patients of ours with ILD, which we discussed at our ILD multidisciplinary meet, and we have a prevalence approximately the same as PGI Chandigarh of about 11%. If you look at the Western data, it's about 4 to 20% depending on where you're looking at the data. What is the pathophysiology of this condition? If you look at the pathophysiology, you'll start with an inciting antigen. And most often there's immune tolerance to these antigens and you just get a normal response, which means there is no damage to the lung. However, when there is a genetic predisposition to this condition, I'm sorry, let me go back to that slide. Okay, when there's a genetic predisposition to that condition, you will have other cells being brought in and then going on to an inflammatory alveolitis, predominantly with lymphocytes, involving both the airway, the smaller airways where the inhaled antigen is deposited, and evoking also a response in the alveoli. If you look at it in a slightly greater detail, the inhaled antigens interact with the antigen presenting cells, and this is mediated through some pattern recognition receptors, which include the toll-like receptors. This stimulates a T helper Th1 response and evokes the influx of neutrophils. The next step moves into stimulating plasma cells, B cells. These produce IgG antibodies that triggers off a complement cascade, and that damages the surrounding tissue on the one hand and enhances macrophages on the other. These macrophages fuse to form multinucleated giant cells and epithelioid cells, and together they form granulomas, and these are poorly defined granulomas. The whole process is mediated through Th1 cytokines, and these granulomas further produce chemotactic factors, and this combined with dysregulated T cell function promotes fibroblast proliferation. So now you're moving from a non-fibrotic phase into a fibrotic phase. And these fibroblasts which proliferate differentiate into myofibroblasts. Sometimes this is thought of being something called epithelial mesenchymal transition. The myofibroblasts produce collagen and an extracellular matrix, transform into fibrocytes, and finally cause fibrosis. So there are 4 steps at this which happens. It moves from a preliminary phase of inflammation, initially neutrophilic, moving into lymphocytic, and finally into a fibrotic phase. And it's important to remember that in any interstitial lung disease, the cause of the injury determines the distribution of the fibrosis. And in HP, we know that the the injury occurs through inhalation. So it comes in through the airways and is predominantly therefore initially centrilobular, and it produces a bronchiolitis and spreads into the alveoli around. So it's predominantly, as you can see down here, an airway-centered fibrosis. But also the severity of the injury determines the severity of the fibrosis, and in HP, from an initially non-fibrotic stage, it can move into a severely fibrotic chronic fibrosing HV, which sometimes resembles very closely, and it used to be previously confused for and can still be confused for an IPF-like picture because of the density of the fibrosis. Based on this, we classify HP into non-fibrotic HP, which is purely inflammatory, into a fibrotic HP, which goes from a mixed inflammatory and fibrotic, or can be purely fibrotic. And the two don't necessarily have to move from one stage to the other. Non-fibrotic or inflammatory HP can remain inflammatory and just can keep recurring without ever moving into progressive fibrosis, and can show minimal amounts of fibrosis. Fibrotic HP is more severe, has a worse prognosis. If you look at the 4-year mortality of patients with fibrotic HP, it's 28%, and more than half are dead by the end of 7 years. So it has a very high mortality. We also refer sometimes to cryptogenic HP or HP of unclear cause. And HP of unclear cause refers to those in whom a culprit exposure has not yet been discovered, but in all other respects they look like HP, and therefore we can recognize that this is HP, but we don't know the cause. So sometimes the term cryptogenic HP is used, though that's not really a good term. If you look at the differences between non-fibrotic and fibrotic HP, non-fibrotic HP tends to occur in younger persons, whereas fibrotic HP in older persons. An unknown antigen is less common in non-fibrotic HP, while in fibrotic HP, probably because a long time has passed that we cannot recognize the antigen that triggered off the whole problem, and patients may have moved away from what is triggering off the fibrosis or the initial HP, and now the fibrosis is going on unchecked without continued exposure to the antigen also. If you look at the vital capacity and the diffusion is low. Vital capacity is low in non-fibrotic HP, but it's even lower in fibrotic HP. And if you look at the lymphocytosis, as expected, when there's active inflammation, there's more lymphocytosis, while in the fibrotic HP, there is less lymphocytosis. Why do some people develop susceptibility to HP when all of us are exposed to those antigens in smaller or larger quantities? The first, as already mentioned, is genetic variation, and these predominantly involve those in the major histocompatibility classes 2. So MHC2, the major histocompatibility complex 2, are responsible for some of this susceptibility. But also we know that viruses may trigger off or aggravate hypersensitivity to these environmental antigens. What do? They increase the antigen presenting capacity of the alveolar macrophages. Because they damage the airway mucociliary escalator, they decrease antigen clearance and allow it to remain longer in contact with the airway and with the inflammatory immunological system. And they also increase the production of inflammatory cytokines that drive some of these inflammatory immunological reactions. The same thing happens with tobacco smoke. Tobacco smoking augments the immune responses to the inciting antigen and also triggers off the processes that lead to fibrosis. So these are two of the conditions that actually enhance the susceptibility to HP. I'm not going to go into this slide because Dr. Jankharia has already given you an excellent talk, and he's the master of radiology in various conditions including ILD, and in particular for this talk he focused on HP. But we recognize, and I'm just mentioning this because we are coming back to this when we look at the diagnostic algorithm, there can be a typical HP pattern, there can be something compatible with an HP pattern, there may be something which is indeterminate for HP, and this mirrors what we see in IPF where we talk about definite, probable, indeterminate or unclassifiable, and we talk about an alternate diagnosis. And this pattern recognition is very important if you want to even start thinking about HP. So I'm not going to go into again this again tells you what the patterns of fibrotic and non-fibrotic HP. But the next stage, once we've considered a diagnosis of HP, is we always think in ILD about a lung biopsy, and the guidelines very clearly tell us that lung biopsy should be avoided in patients in whom a confident diagnosis of HP can be made following a multidisciplinary discussion of the clinical, the radiological findings, the exposure history, and the bowel lymphocytosis. So based on those four, you can decide that you're very confident about a diagnosis of HP and avoid the lung biopsy. But if you do a lung biopsy, we again describe features that are very typical or definite for HP, probable for HP, and indeterminate for HP. And I'm just going to focus on those that are very typical of HP. You need to have all these three. You need to have a cellular interstitial pneumonia. You need to have cellular bronchiolitis. You have poorly formed non-necrotizing granulomas, and I'll repeat that, poorly formed non-necrotizing granulomas. Necrotizing granulomas, as you know, are typical of tuberculosis, and well-formed non-necrotizing granulomas are more typical of sarcoid. Here they are poorly formed. And of course, you must have absence of any alternate diagnostic features. And I'll come back to this later. And these all suggest non-fibrotic HP. But what happens in fibrotic HP is you tend to get a chronic fibrosing interstitial pneumonia, unlike the cellular interstitial pneumonia that typifies non-fibrotic HP. The fibrosis tends to be predominantly airway centered, as I mentioned to you earlier. You again can see a few poorly formed non-necrotizing granulomas, and again you must have absence of any alternate features. And typically what features suggest an alternative diagnosis is if you see a lot more plasma cells than lymphocytes, if you see a lot of lymphoid hyperplasia, if you see extensive well-formed granulomas which may be sarcoidal, non-necrotizing, or necrotizing as in TB, and finally if you see aspirated particles, which you can sometimes pick up when you look at it under the polarizing microscope, as you may see in silicosis, for example, and other occupational exposures. So that weight is different should lead you away from a diagnosis of hypersensitivity pneumonitis. One of the things we resort to often, but perhaps not enough, is bowel lymphocytosis. And bowel lymphocytosis, using a cutoff of more than 30%, is very useful to differentiate between chronic HP and IPF. And you can see that's a huge difference. Between chronic HP and non-IPF interstitial pneumonias, again a good difference. But it cannot differentiate adequately between chronic HP and sarcoid, where again you might find lymphocytosis with altered CD4-CD8 ratios. And you can see in this meta-analysis they showed that a cutoff of approximately 42.75 was noted, and that's a pretty high figure. But you can also see that there's a huge heterogeneity between studies, and therefore I think more needs to be looked at this. So essentially what do we know? We know that bowel lymphocytosis varies broadly between fibrotic and non-fibrotic HP. It may be unnecessary when there's a very high pretest probability of HP, but unfortunately this is also when it has its greatest value. When there is a high pretest probability of HP, you can make a diagnosis without even doing bowel lymphocytosis. But if you do it, then it adds a lot to the value of reaching the final diagnosis. However, if there's a discordance between the history and the imaging, it lowers the overall diagnostic confidence, and then you may resort to bowel lymphocytosis. And as I said, a cutoff of more than 30% increases your diagnostic confidence for HP. But more importantly, absence of lymphocytosis when you have a non-fibrotic HP lowers the probability that you're really dealing with HP, and therefore in a non-fibrotic condition, no lymphocytosis, I don't think this is HP. So in patients with a fibrotic ILD, on the other hand, a bowel lymphocyte count of more than 30% is highly specific, but its absence does not rule out HP, and in such conditions you may think of pursuing a lung biopsy. How about searching for the offending antigen? So what you really need to do is you need to take a detailed history, and often in our ILD clinics we use a structured questionnaire. But it must be remembered that no questionnaire is appropriate for all settings. We do use specific IgG tests. They confirm suspicious exposures, and sometimes, especially in research, they may point to an undetected exposure. But you cannot really rely on these because there are no well-defined predicted values, and you cannot differentiate based on IgG between sensitization to the antigen and actual disease. And in special centers, expert clinics, they can perform specific inhalation challenges. And this is one of the structured questionnaires that is used. But please remember that even in the structured questionnaire, which came from the Chest Society, they said list any unusual exposures that you might that you feel might be related to your lung disease, the patient questionnaire, of course. So let's look at the algorithmic approach to HP diagnosis, and this comes from the ATS 2020 with Dr. Ganesh Raghu as the lead author. They start off with interstitial abnormalities which suggest an ILD. Always ask about an exposure assessment, because removing the person from the antigen which is causing the problem is the most important steps. Always ask about an exposure assessment. Follow up with an HRCT scan. And then when necessary, you do a bronchoscopy with a bronchoalveolar lavage and look for lymphocyte dominant features, and you also do a TBLB when necessary. Either with or without a TBLB, then you go on to assess exposure. And if you have a combination of exposure, typical HP pattern on HRCT, and bowel lymphocytosis, at a MDT, a multidisciplinary discussion, you can make a high confidence diagnosis of HP. On the other hand, if you have any other combination other than all these three, that is exposure history, typical HRCT findings, and bowel lymphocytosis, then your diagnosis is not very clear. Review the exposure history, go ahead with a multidisciplinary discussion, consider a biopsy, either a transbronchial lung biopsy, forceps biopsy or cryobiopsy, or a surgical lung biopsy. Go back to your MDT and then decide on your diagnosis, and that is based on putting these all together. So as I said, if you have all these features, typical for HP, typical for HP, you can make a fairly confident diagnosis when you have definite history of exposure and you have a bowel lymphocytosis. You can be sure you have it. So when you have all these, or you have a typical HP histopathology, you can make a very definite diagnosis of HP. Even if you don't have a typical HP histopathology, but you have a probable histopathology in the setting of a typical HRCT, you can still make a definite diagnosis. Even if you don't do a histopathology, but you have a bowel lymphocytosis, histopathology is either not done or indeterminate, you can either say it's definite, or at least with a high confidence make a diagnosis. However, if your HRCT is only compatible, you don't have a history of exposure, or it is indeterminate for HP and you have a history of exposure or not, you cannot rule out HP, but you cannot rule it in confidently either. So at the end of an MDT diagnosis, I'm sorry this is a little confusing, but you have to decide whether you're definite about your diagnosis, you have a high confidence in your diagnosis, you have a moderate confidence, you have a low confidence, and you can say, no, I'm not even sure I have HP, but I can't completely exclude it. So that is the way you put it all together. But you can actually simplify this. So you have an identified antigen exposure, a typical HRC pattern, bowel lymphocytosis, at the MD you can say diagnostic for HP. Any other combination with a compatible pattern, bowel lymphocytosis is greater than 30%, again you can make a high confidence of HP. You don't have all these, then your confidence in your diagnosis reduces. So let me summarize the ATS JRS ALAT guidelines for 2020. A thorough exposure history, IgG testing, bowel fluid, transbronchial biopsy, either forceps or lung cryobiopsy. When all else fails, you can resort to a surgical lung biopsy, and all have a very low confidence. The suggestions for all these have a very low confidence in the estimated effects, and they are largely based on expert opinion. Who are the people you worry about when you make a diagnosis of HP? There are certain intrinsic factors: older, male with a genetic predisposition, where you've not been able to identify the inciting antigen, where a person has a very prolonged exposure to the inciting antigen, when they are smokers, when their physiology suggests there's a low DLCO and a low FVC. If you find that there is no more bowel lymphocytosis suggesting you cannot reverse this condition, when you pick up a lot of fibrosis either on radiology or on histology, all these carry a poor prognosis. Having made a diagnosis, what is the management of HP? Now, things are very unclear in HP, unlike many of the other diagnostic ILDs that we've seen. You identify and try to eliminate the inciting antigen. That really is the foundation of all treatment of HP. The rest of management, unfortunately, is uncertain. With corticosteroids, systemic corticosteroids, you see an initial improvement, but studies have never shown a very definite evidence on the course or lung function in the long term. And it doesn't even show that steroids may prevent progression to fibrotic HP. And yet, we all use it, and we must be cautious and try and reduce the exposure to steroids as much as we can. Once we're confident we've reached either the goal we want to set for ourselves, or we find that steroids don't seem to be making much of a difference. What about the role of immunomodulators? They can help you reduce the dose of steroids, and what we use are typically MMF or azathioprine, and there's very little evidence. If you look at the studies, they've shown very, very small studies, but what they have shown is there is an improvement in DLC or FVC after 1 year of treatment with either MMF or azathioprine. But most studies have not shown that adding azathioprine or MMF to prednisolone is any way better than prednisolone alone. Small studies have been done with rituximab. There was a study of about 20 patients which showed that treatment with rituximab over a period of 6 months led to stabilization or improvement of the FVC and DLCO in patients with hypersensitivity pneumonitis whose disease had not improved following antigen avoidance and corticosteroid therapy. Antifibrotics. We spoke about fibrotic HP, and we know that antifibrotics work in all kinds of progressive pulmonary fibrosis. And the INBIL study showed us that nintedanib worked as well in the progressive pulmonary fibrosis cases as it did in IPF. And over a year, the improvement that you got, or the reduction in the rate of decline, was 57% compared with placebo, almost identical to what we saw in the INPULSIS trials of IPF. There was also apparently in the INBIL study, which looked at all progressive pulmonary fibrosis, reduction in acute exacerbations or death. However, remember that only about 26% of patients in the INBIL study were composed of fibrotic HP, but that's a good number. And if you looked at the subgroup analysis, though it was not powered for this, it seemed to work equally well in all the subgroups, whether you're talking about NSIP or you're talking about CTD-ILD or fibrotic HP. Nintedanib seemed to work well in all these. There's less evidence for pirfenidone, but what evidence we have, again, small studies, 23 patients retrospective study, slower decline in FVC after pirfenidone initiation compared to the previous 6 months before initiation. If you looked at change in FVC after 1 year of treatment, when you combine pirfenidone with prednisolone and azathioprine, compared to prednisolone and azathioprine, again, not much of a change really. If you looked at the RELIEF study of pirfenidone in progressive pulmonary fibrosis, they terminated it early, unfortunately, because of poor recruitment. But again, you saw the same signal as you got with the INBIL study. 57 patients with HP had a better outcome, slower decline in FVC over almost a year as compared to placebo. So to summarize this part of it, non-fibrotic HP, you try and remove the inciting antigen. If the lung function is not severely impaired, you monitor closely. If the lung function is impaired or the disease appears to progress, consider for corticosteroids. In fibrotic HP, or when the disease is severe or progressive, you consider immunosuppressive therapy and give a trial of that. In patients who have progressive pulmonary fibrosis, consider antifibrotic therapy. I'm going to skip this, but remember that the entire decision initially is based on identifying the source, avoiding the source, preventing re-exposure to the source, and deciding whether you're dealing with a predominantly fibrotic or a non-fibrotic non-fibrotic HP, and then deciding at what stage, if it appears to be progressing, do you want to add on corticosteroids or continue with corticosteroids and then bring in a steroid sparing agent. On the other hand, if it's not progressive, then you decide when you want to withdraw the steroids, taper them off gradually. Of course, other things common to all ILDs include symptomatic and supportive care, patient support groups, long-term oxygen therapy, which is not strongly evidenced, but all of us use it and it seems to work, vaccines, pulmonary rehabilitation, and of course, considering lung transplant. So I'll stop with a few take-home messages. HP is a complex ILD that involves an exaggerated immunological response to an inhaled antigen, which sometimes progresses to fibrosis. It's now classified as non-fibrotic and fibrotic forms. The diagnosis is based ideally at an MDT discussion on a history of exposure to environmental or occupational antigens, typical changes on HRCT, bowel lymphocytosis greater than 30%, and where a biopsy is done, HPE showing cellular interstitial or fibrotic interstitial pneumonia, bronchiolitis which is airway centered, and poorly formed non-necrotizing granulomas. Antibody tests may provide a clue but cannot differentiate between sensitization and disease. Treatment mainly consists of removal of the offending antigen. The role of corticosteroids and immunomodulators, while widely used, is uncertain. When progressive pulmonary fibrosis occurs, use an antifibrotic. At all stages, consider supportive and symptomatic treatment. And in more advanced disease, especially if progressive, consider lung transplant referral. I'll stop at this point. Thank you very much for a patient listening and hand it back to the moderator. Good night.
Thank you very much, Murli. Wonderful talk, very comprehensive. And to be honest, you've covered almost every aspect of hypersensitivity pneumonitis. So what's the job of the panel then? I think what we're going to do for you over the next 30 to 40 minutes is to try answer some questions for which there might be some dispute, but the evidence is not very clear, and also try and highlight certain areas which Dr. Murli Mohan has spoken about, but which might still need highlighting with clear messages, which our elite panel is going to do over the next half an hour. So let me introduce you to my panel. So we'll start off with the youngsters. So start off with Dr. 𝐃𝐚𝐭𝐞, who is a consultant pulmonologist and critical care specialist from Louisiana. So now what strikes me about 𝐃𝐚𝐿 the most, I've known her for a few years now, is her enthusiasm and passion for academics, the drive and the organization that she brings into academic activities. And it's an absolute pleasure to have 𝐃𝐚𝐿 with us today. So she represents the northern part of our country along with Dr. Anant Mohan, who I will come to in a moment. The next lady on our panel is Dr. Vrushali Khadke. So Vrushali, again, is a practicing chest physician and interventional pulmonologist for a lot of years now. I mean, she's very young, but she's been practicing for 13 years now in Pune Hospital, various other private hospitals, and again, a passionate academician. She's part of training programs in intervention and is a keen academician. She's also got many other feathers to her cap. A lot of you would know she's a very keen singer. She dances wonderfully well, and she's got a lot of literary skills, which will take me a lot of time to go through. But she's, like Dr. Murli Mohan, has got lots of facets about her, which maybe we'll get to know another day. But ILD is the topic today. The next person on the panel, my dear friend, Dr. P. Arjun. Dr. P. Arjun is from KIMS Trivandrum, and academics around the southern part of the country, I think, centers around Dr. Arjun. So he's a DNB trainer. He takes the lead in academic activities in the southern zone and throughout the country. I have been fortunate enough to partner him in multiple documents, consensus documents, research projects, etc. And you will find him a priceless addition to this panel today. And then last but not the least, Dr. Anant Mohan. Dr. Anant Mohan has many feathers to his cap. He heads the Department of Pulmonology at the esteemed All India Institute of Medical Sciences in Delhi. He is, I mean, I don't need to say this, he's a keen researcher, he's an academician, he's a PhD, so a double doctor, so as to say. So Anant has headed a lot of work in interstitial lung disease, as has AIIMS. And we'll come to him with the questions which are probably the most challenging and perplexing. So with that, let me start off, and I'll start off with Kirat. So Kirat, we heard Dr. Murli Mohan speaking about antigens, and he went through a very thorough list about various inciting agents. We know that these inciting agents vary in the different parts of the country, which is why we have a panel which covers the various parts of the country. However, a question that I've often been asked is, do you think you can have hypersensitivity pneumonitis, and note I'm asking HP rather than chronic HP, after first exposure to the offending antigen? Or do you always need prior exposure to develop HP? So starting with you, Kirat, I think that's an important question to start off with, and we'll sort of, as an offshoot, go to various questions after that. Dr. Kirat Sibia.
Thank you, sir. It is indeed a very interesting question because it makes us think what we're dealing with when we think of HP. So first of all, thank you for the very kind introduction and always inspiring us. Thank you, sir. And so when we think of HP, we must look at the pathology behind. HP is essentially an overlap of type 3 and type 4 hypersensitivity reactions. So your question is that whether one can have HP at first exposure to inciting agent. So certainly, sir, acute hypersensitivity pneumonitis. So when we think acute hypersensitivity pneumonitis, it can set in very quickly after exposure, first exposure. It depends on the load. If someone has heavy exposure, then after a few hours, 4 hours, 9 hours, 12 hours, they can develop fever, they can develop breathlessness, and the typical acute hypersensitivity pneumonitis, we get that picture.
Wonderful. So I think sort of summarize what you said, Kirat. You can get acute HP after a large antigen exposure, and the symptoms are acute. These symptoms would go if you manage to remove the individual from the inciting agent for a couple of days. The symptoms go away. However, with continued exposure, you go to what was previously called subacute and then called chronic HP. That's with protracted and continued exposure. Your delayed hypersensitivity reaction is more relevant in case of chronic HP, which you cannot develop without having had exposure before. I think that's the crux audience of the question that I was trying to ask. Let me come to another question, and let me sort of, Anant, please.
Yeah, hi. So just one quick addition to whatever Dr. Kirat said, I think she covered all the points. Acute HP after first exposure, another parameter might be the host predisposition, because we know that HP is a genetically predisposed disease. There may be some people who are more predisposed to it. There are genetic factors, polymorphisms have been seen. So if a person is highly predisposed in whatever way, then probably they are more likely to develop HP after the first exposure. Might be.
Yeah. So that's an important point. It's a bit like the asthma algorithm, isn't it, Anand? So you have the environment, and then you have the host along with the genetic driver. And if you have all these additions, that would be the inciting time when you have the disease process, isn't it? So that the asthma, I think that's an important point that you brought in, Anand. Thank you for that. So I'll come to Brushali. Brushali, I know you've got a comment. So I've got a question for you. You can say the comment first, and then we'll go to the question. So what did you want to add, Brushali? You say that, and then we'll come to the question.
So possibly, like, definition says that, it is repeated exposure, but possibly there is sensitization with so many things. We're exposed to a lot many things after we think. So that, the sensitization can ensure that your single exposure can give you an HP. Maybe that is one more thing which you're not aware of, that there has been a sensitization in addition to our genetic predisposition and the environmental and whatever the antigenic load is. That's what I wanted to say, sir.
Yeah. So, Vrushali, fair point, actually. So, the inciting agent and the sensitization that you spoke about is more for chronic changes. So, with a genetic predisposition, with a large antigen exposure, you can get an acute reaction. The reaction that Kirat described, you can get that sort of a reaction with an acute exposure. But you rightly said, if you've had repeated low-grade exposure to the inciting agent for a long time, you've probably been primed to have a long-term reaction to the agent. So that's again a fair point. Let me come to you, stay with you, Vrushali. So we heard both Dr. Murli Mohan and Dr. Bhavin Chankaria a little while ago speak about a comparison between a UIP pattern, so between IPF and chronic HP. So my question to you is, in your clinical practice and what's available in the literature, do you think these two are disease processes, causes of interstitial lung disease, which are sort of closely allied to each other as far as symptoms, radiology, histology is concerned? Or do you think the distinction between these two diseases is relatively easy and should be made in clinical practice with relative ease? Vrushali.
So that's, I think, an absolutely wonderful question, because I think we deal with this quite day in and day out. Both of them pointed out the importance of having a previous imaging, which many of the times we are not privy to. So basically, I think we based on the radiology or whatever we see, we overdiagnose UIP pattern, and possibly we are leaving a large cohort of patients who would possibly be an HP which will progress to a fibrotic stage. So based on this, based on the history, I think a history or an MDD over here is very important, and we should keep HP at the back of our mind in a patient who is presenting with a fibrotic kind of a picture. Regards the histopathology, sir, I think, there are certain distinctions which are very clear. That is, if you have an airway-centric disease, like sir was speaking about, so it is a bronchiolocentric disease, then the presence of these granulomas and a lot of cellular infiltrate, which may be missing in the chronic HP, but the presence of granulomas may point towards the presence of an HP in a patient when you have done a biopsy. Regarding radiology, sir, if you have more of the triple density sign, or along with obviously the clinical history, and where you have the non-dependent kind of an honeycombing, or it is more in the upper lobes, the anterior segments, and with the history, I think we can make a subtle differentiation. But what is very important is that we have to keep in mind that all which looks UIP on radiology need not be, and as a clinician, it's our prime job that we find out if this is another process which has led us to a UIP. Hopefully, I think I answered most of it, or do you need something else specifically?
No, Vrushali, I think that's great. So I think when we are talking about fibrotic HP versus IPF, it's almost impossible to distinguish these two fibrotic diseases on the basis of symptoms. So I think that's a point that you made. The second point about radiology, I think the most important part is that you don't really have the apicobasilar gradient that we spoke about in IPF in patients with chronic HP, other than a small percentage of people with chronic HP who seem to have a UIP pattern. But that's about a 20% odd number of patients. I think you said beautifully about the bronchocentric disease in patients with chronic HP, whereas a more peripheral subpleural distribution of disease in patients with IPF. So that's another marker. But there's exceptions to the rule. There are patients chronic HP who have a pattern which is similar to IPF. And then again, the histology that you spoke about, I think very important. Ill-formed granulomas, which go with the nodules that you find in patients with chronic HP, is something that you would not get in patients with IPF. So I think that broadly encompasses all of what we needed to say. I'll come to you, Arjun. Similar question. And there was this study which is from about 10 years ago, 11 years ago, which looked at a cohort of patients with chronic HP. And they found that about 40% of patients in that category, when they were re-examined, investigated further, came out to be IPF. Now, you heard Dr. Murli Mohan, and we were all a part of the ILD India registry anyway. About 47% of patients with chronic HP. Do you think we either overestimate patients with chronic HP in a high prevalent chronic HP zone, or do you think we sort of underestimate patients with IPF in India, which has given rise to the 47% that we speak about? And I'll take a comment from you, Arjun, and then I'll move to Anand for sort of a north and south, the distribution of chronic HP and the experiences. So start with you, Arjun.
Thank you, Raja. Thanks for this opportunity. As we know in the study, the Indian registry, about 47% of the patients were diagnosed as having HP. When we look into the centers, most of the centers were in the northern part of the country. And one of the reasons why they have attributed the increased prevalence of HP is the use of air coolers and the isolation of these fungi from the air cooler and the fungi and bacteria. So that is one thing. And actually, Anand and his group have written an excellent critical appraisal of that as letters to the editor into the Blue Journal, in which they have pointed out other factors as well. The lack of biopsy in more than 90% of patients did not have biopsy. So probably had that also been done, perhaps the percentage would have changed. Having said that, we should also probably think whether there is some genetic predisposition in the people in the northern part of the country, which makes them more prone to develop HP. In my practice in the southern part of the country, HP is not the commonest type of ILD that I see. Perhaps because I work in a tertiary care center with a strong rheumatology department, we get maximally CTD-related ILDs. So probably there's a selection bias, but even then, I believe that this 47% is a bit overrated.
Sure. So I'll come to you, Anand. So 47% in the ILD India registry, 11% from PGI Chandigarh. Dr. Arjun saying that the numbers in the south are far lower than what we quoted in the ILD India registry. So AIIMS, not very far away from PGI. What is your experience? Northern part, chronic HP, what numbers do you normally see? And what do you think is do we overestimate, underestimate numbers?
I think the estimation is quite skewed, because of it is all because of the selection bias and the referral bias, I would say. The same thing that may happen at PGI, the same kind of problem may happen at our place as well. It may not be for sarcoidosis, it may be for something else, for probably again for CTD ILDs, because here again we are seeing quite a high percentage of CTD ILDs. Definitely, I would not say we are seeing almost half of all our ILDs as HP. But so I think the reasons for this marked difference in incidence across the country is again multifactorial. Of course, there may be factors unknown like genetic predisposition, the type of inciting antigen involved are variable across, all that is fine. But then it is about selection bias, the type of workup we do, the type of thing we think of as physicians, and the type of cases that come to us, because we don't have community surveys. You see, because whatever we have are all hospital-based surveys. Hospital-based surveys will always suffer from some or the other referral bias. Your registry was an attempt to try and negate that bias by roping in multiple centers. So that was probably the best possible one could do. But again, because of the kind of centers which were there, again, more in the north, more in the south, probably it got a little skewed. So I think that these are the reasons.
Sure. So Anant, I'll sort of spend another minute on this before we move on. I think one of the challenges we have in the diagnosis of chronic HP is that the inciting factors that we identified in the ILD India registry are actually widely available, and exposure to the inciting agent does not translate into disease, if you see what I mean. So for instance, we saw air coolers, air conditioning as being important factors. We found exposure to pigeon droppings, pigeon feathers as being important factors. We found moldy hay, mold on the sort of inside of air conditioning, coolers, etc. as being inciting factors, which is widely available. And I think to try and extrapolate that and say all of the fibrotic disease that we have in people who are exposed to this is chronic HP probably makes us translate a lot of other diseases like IPF into the chronic HP category. And I think that's something that people have noticed the world over, But have that, I think, carry home message for the audience. our chronic HP numbers are probably far more than what it is in the West. It might not be as high as 47%, but the numbers are higher. And up in the north, sarcoid is another very important disease, which we'll speak about in one of our later modules. But again, that's an important disease. I think Vishali very nicely spoke about genetic factors. These are variable across the country, and that might also cause the change in numbers across the country that we see in chronic HP. So let me stay with you, Anand. I've got a question. So, when we started studying about HP, we subdivided them into acute, subacute, and chronic. Then we got rid of subacute. We thought that was more an overlap zone between acute and chronic. So we got rid of subacute, and then we said it's acute and chronic. And now we say it's fibrotic and non-fibrotic. Do you think these classifications matter? And if they matter, why does it matter? Why do you think we have needed to make this shift from acute and chronic to fibrotic and non-fibrotic? Or do you think both these classifications have their importance in clinical practice?
I think your last statement is what I would agree with most, because I think both these still have their own importance in their own way. The acute, subacute, chronic was symptom based. So symptoms are obviously going to be a key factor in deciding the onset of a disease. So they have their own place. Now, why they were probably replaced, the reasons given are that, like you said, there is an overlap and they do not reflect the actual outcome and progression of the disease. So acute HP may improve, may not improve. It may progress, it may not progress. A subacute HP may behave either way. A chronic HP also may behave either way. It may not necessarily lead on to chronicity. It may improve, then again there may be an exacerbation. So they did not reflect the outcome of the disease. That is why, to objectivize this further and help make management decisions, they relied more on radiology now. Because of better and better radiology coming up, now, as you see, everything is a large proportion of HP is CT based. Let's face it, So based on that, they've now made it into fibrotic and non-fibrotic to try and decide, okay, these are the people whom you should really aggressively treat, and these are the people in whom probably you have to either try and look for something else or do a much more tempered. So that was the reason for this shift. But I still feel both have their own importance in their own way.
Sure. No, wonderful answer, Anant. I think you covered the entire spectrum nicely. I'll just add one point, and please tell me whether you agree or not. So I think one of the challenges we faced with the acute, subacute, chronic classification, that we did not see the patients in that spectrum. You wouldn't see a patient having an acute reaction, then sort of the inciting agent staying for a few days, you become subacute, and then you become chronic. Like you said, these patients come with cough and breathlessness, and often when you do a CT, either you see predominant GGOs, you see the bronchocentric granules that actually spoke about, or you see the fibrosis, the honeycombing, the traction bronchiectasis, which puts it in the fibrotic category. Hence, also the shift, the fact that you don't get the acute, subacute, and chronic, but the fact that you get more of fibrotic and non-fibrotic, which makes the difference, I think. Do you think that's probably the carry home message, Anant? Or yeah?
No, I agree fully. I agree fully on that. Sure.
Let me come to Kirat again. Kirat, these you heard Dr. Murli Mohan speak about the prompted case report forms. The inciting agents, etc. We just said that there's a variety of agents that can trigger acute, subacute, or chronic HP. Now, do you think we should have patient-reported inciting agents, and do you think these lists need to be updated in various parts of the country? Or do you think because we cannot normally establish a causal relationship between the inciting agent and the disease process, a broad spectrum number of agents on a similar question box ticked off when you're trying to diagnose chronic HP based on symptomatology and radiology is enough? So what I'm trying to say is tailor-made for various parts of the country, or one big umbrella without sort of trying to go into individual patients, but ticking off from a box is what the requirement is. And I would put the same question to Arjun after this. Kirat.
Thank you, sir, for the question, sir. This again brings in the value of studies like the ILD registry. because then I believe that it is essential that we have an umbrella list. This is what I believe in, because then we might otherwise be missing out on a lot of causative factors, because we might assume in this area this is not the common agent or common antigen. But at the same time, having an umbrella list for a few years while we have another registry, and then coming to a more area specific list might be much later. Much later in the sense 10 years later or 15 years. Taking that long to really refine it. This is what is required. You're all talking about how there's a genetic predisposition difference in the different parts of the country, and with the geographical difference, the environmental difference is so huge that it makes sense to have an umbrella list as of now.
Yeah. So Kirat's vote, Arjun, is for an umbrella list for all parts of the country. Do you think that's the way forward, or do you think the north and the south and the east and the west are so far apart in this country that giving patient recorded triggers, inciting agents is better? What do you do in your clinical practice, Arjun?
I actually partially agree with Kirat as what she has said. At least to start with, we should have a broad umbrella-based approach. And then we should develop a validated list so that we can actually focus on that. The Indian ILD registry also is pointed to that direction, because we know that there are differences in various parts of the country. Till such time we know what is specific in each geographic region, I think it's better to have an umbrella list and then break down to match the local requirements.
Yeah. So I think the evidence globally also points to this. In Europe, with their much lower number of chronic HP, they had 11 different countries registry looking at inciting agents, and they tried to come up with inciting agents which were different. Now, when they did this, they came up with such a heterogeneous list that was difficult to actually incorporate them into a list which they would ask their patients. So across Europe, you have this paper which is published from Italy, where they actually use the same sort of umbrella list that you spoke about. If you look at the ILD India registry data, we have a drop-down list that Dr. Murli Mohan showed. And a list similar to that is something all of you out there listening to us today should use when you feel someone has suspected chronic HP. Or some people would say you should do it for all ILD patients across the board, because the CT patterns could be widely different. So I think that's an important message from all of us. Let me come to you, Vrushali. Vrushali, auscultating. We'll start off with a little bit of clinical examination, which we probably don't do as often as we should do in clinical practice. So listening to a patient's chest and thinking, could this be chronic HP? Do you think that's a possibility, or do you think it's more about listening to the bases and hearing crackles and saying, okay, this is ILD, rather than being specific about chronic HP?
Well, sir, what I've seen personally, and possibly, it is aided by what we see on the histology, is that, you hear these squeaky sounds. So the crackles are there. You have the inspiratory rals, which are basally everywhere. But when you start hearing those squeaky sounds, is at the time my mind is peaked off, that possibly this is an HP. When my clinical, the history taking has also included HP. So yes, because it's an airway-centric disease, then having some amount of airway-related wheeze, or not a wheeze, it's usually not like a wheeze, it's a different kind of a squeak sound, might help us in the diagnosis of, I can think in terms of go towards an hypersensitivity pneumonitis over the other forms of ILD. Right.
Sure. So very important point, Vrushali. I think this is something that the audience should remember. The squeaks that we speak about is because this is actually a small airways disease which spills over into the interstitium. So like you heard us saying a little while ago, bronchocentric disease, small airways disease, spilling into the lung interstitium. The squeaks are from the small airways, the crackles are from the involvement of the interstitium. And that's how this is different from someone with IPF, which is more a subpleural disease where you hear just the crackles and no involvement of the small airways. That's an important tip for all of you when you listen to these patients' chests with chronic HP. Vrushali, yes.
So just a thought that came around. I see much less honeycombing in the chronic HP patients than the not honeycombing. I meant much less clubbing in the chronic HP
Sure.
going towards a fibrosis rather than having
Absolutely.
in a UIP patient. Sir.
Yeah.
So
Yeah.
on that note, even I would just like to point out, we have done around 168 medical thoracoscopic lung biopsies for patients who did not fit into the UIP pattern and didn't have your other things. And we found that in out of these 168, 12 of them were HP and 70 were UIP. So this is a biopsy documented. This is only for the chronic kind of patients.
The fibrotic patients. Correct.
No, the non-fibrotic.
Yeah, correct. Correct. So, as a point of interest, and I sort of need to move on, but as a point of interest, more and more people feel that chronic HP is actually an airways disease. Most of the trials with inhaled drugs in the ILD space are actually in chronic HP, as opposed to the other diseases we have. So I think it's more about watch this space. Let me come to you, Arjun. We'll come to talk a little bit about diagnosis, and I'll talk to you about doing a BAL in patients with chronic HP. Is it something that you do in clinical practice? We heard what Dr. Murli Mohan had to say with the numbers, but do you think that's something that we do in our Indian population with success? Or do you think recognizing the cells the way they have been described in the literature is something we often don't get even after doing a BAL in clinical practice? So what do you do for BAL in chronic HP? What's the message for an Indian audience, Arjun?
Very correctly put, Raja, because even in our practice, we do not do BAL routinely for diagnosis of chronic HP, basically because we are not very happy with the results that our pathologists give us in terms of quantifying the cells. So most often we do not get the desired result. The other thing is that if you have a very typical pattern, for instance, the non-fibrotic HP, where the soft central lobular ground glass nodules and an exposure is there, then of course there is nothing, there is no real indication to do a BAL because it's not going to change how we are going to manage the particular patient. In chronic HP, of course, when you have the other differentials like fibrotic NSIP or UIP, and then you want to take a call on whether the patient is not fit for a biopsy and you need to start the patient on steroids. If you get an elevated lymphocytes, probably that would be one pointer to help us determine whether the patient may benefit from steroids and, of course, to rule out infection. But in routine practice, we usually do not do that.
Yeah. Yeah. So I agree with you completely, Arjun. So in my practice too, similar to yours, we often do a BAL, but doing a BAL does not seem to add very much to the diagnosis because we don't really get the classic lymphocytosis. So I'll come to you, Anand, with this BAL question, a one-liner, your experience in All India Institute of Medical Sciences, but also about the biopsy question. I'll sort of elaborate a little on the biopsy question. Do you think the number of biopsies we're ending up doing in patients with chronic HP is gradually going down because we've got such robust HRCT criteria for the diagnosis of chronic HP? And if you had to do a biopsy, there's a lot of questions in the question box about doing TBLBs. Would you do a TBLB? Would you do a cryobiopsy? And I take it you wouldn't be doing a VATS biopsy, but tell us your biopsy techniques and indications for doing biopsies in patients with chronic HP. Anand.
Right. So, Raja, first of all, yeah, I also agree with the BAL thing because we also do quite a bit of BAL wherever we really suspect HP, but it really does not add much to the diagnosis. It is recommended. So, ATS and chest, they have slightly different recommendations for when to do BAL. ATS probably is a little more aggressive in that sense, but both of them do recommend as part of the algorithm. The lymphocytosis, cannot differentiate. It can differentiate statistically, but in real life, it has not really made much of a difference, except maybe to rule out infections if really we are suspecting TB or something at some stage. That is one. Regarding the biopsy question, yeah, so that's another important thing. I do agree that biopsy rates probably have come down, and now it is limited to, center to center. So depending upon the practicing physician or pulmonologist and up to him and up to his experience and his criteria facilities. So usually with all the robust imaging going on, we are able to now so nicely categorize HP most of the time. If we have all the other things along with us, that one may not need to go for an invasive procedure that is also there. If we don't, or if we feel that we are kind of likely to miss something, then we do a TBLB. Actually, we actually do a normal TBLB, a simple flexible bronchoscopic TBLB also in most of our cases. And if we get 3 or 4 pieces, then many times we get a reasonably good diagnosis, including the granulomas, etc. Now, whether to do, and of course, now we know that in a fibrotic, predominantly fibrotic kind of HP, usually one doesn't go ahead with the biopsy unless we strongly suspect something else going on, like a fibrotic sarcoid or something. Even there, role of a biopsy is not very clear. Now, role of a cryo-TBLB and VATS, etc. So again, we can all talk about statistics. No doubt, cryo-TBLB has got a high yield compared to conventional TBLB. Conventional TBLB has around 50% yield. That will have around maybe 80 to 90% yield. It all depends upon the risk-benefit ratio, facilities available, and whether you are willing to take up a 25 to 26% risk of pneumothorax and hospitalization cost and all these things along with it. And of course, we have to do it under GA, etc. most of the time, although now some people are doing it without that as well. So that is, and even all the guidelines, they recommend cryo TBLC, that is cryo, this thing with a weak recommendation. So in a very selected cases, after a good multidisciplinary discussion, when all other non-invasive and all other methods fail, then if you really strongly suspect, one should go ahead with it.
Sure. Wonderful. So just to summarize what you said, Anand, so BAL, we all agree on the panel that it is theoretically of great value, but for some reason, we don't really have the results that we should do in analyzing the cytology of these patients in the long term. We don't really find the lymphocytosis. Maybe we time it wrong. We do it during an infective exacerbation, which makes us see the neutrophils that we see in these patients. So that's about a BAL. The biopsy, as you said, the numbers have shrunk greatly because of the better history taking, the radiology that we do, the CT classification now we have for chronic HP. In a subsegment of patients where we are doing it, which is a small number, we would start off by thinking about the TBLB. And in a very small proportion, maybe where you're trying to make a distinction, Anant, between chronic HP and IPF, because this diagnosis also has a lot of prognostic significance, that's where you might end up doing a cryobiopsy, but that's a very small number. And you have to, as you said, take the risk fraction and the benefit fraction into account before you go ahead and do a cryobiopsy in a small percentage of patients with chronic HP. Let me come to you, Kirat, about another question, which is sort of, there's a lot of questions in the question box about this. So detection of offending antigen in patients with chronic HP. Does that help an individual? So I'm a patient. Does identifying an antigen as a cause of chronic HP in me make a difference? Do you think circulating antibodies against sensitizing antigens is important? And this two categories that we talk about, exposed but never diseased versus even never exposed and never diseased. So you have been exposed, but you've never had the disease, and then you've been exposed but not diseased. Do you think this sort of categorization confuses issue when you're trying to detect offending antigen or antibodies in individuals?
Sir, let us take it point by point. Exposed but not diseased, exposed but diseased. So differentiating between the two is certainly helpful. Someone who's exposed but not diseased is not coming to us for treatment. Someone who's exposed and is diseased, we have CT findings, they are looking for answers, we are looking for answers. I've had cases where having a positive HP panel has helped me when we were not able to make sense of anything. And CT at times, we all know, can be so vague, the findings, they may not be that specific to HP. And so having said that, the antibodies after exposure, after a patient is not having exposure for some time, there's a exposure vacation, the antibodies go down. That is also documented. That could be a reason for not being able to detect antibodies in a person who's symptomatic, has been exposed, and is also sensitive. Coming to looking at antigen from the point of removing the antigen, we all assume that it's not like someone is going to change their house. Maybe the person is living on rent. We should at least give them that option. Maybe the person is using a down duvet, or maybe using, in our place, we use down jackets because it's so cold. And so these kind of things actually make a difference. And I feel as much awareness possible regarding the offending agent, trying to identify and trying to educate the patient, I think we should certainly do that. Because one thing which is known to make a difference is removing the person from the environment where the antigen is present. We all know that if the birds, the bird antigens are in the air, they will take about 18 months, may not still be cleared fully. But a lot of people do make some very difficult choices in life. I know someone who moved
Sure.
from Shimla to Chandigarh because they were highly allergic to pollen, and they made that change at 60, 70 years of age. Like the husband made that change for his wife. So people do make a lot of changes, but they would be so thankful if we are able to guide them.
Sure. So very, very nice points, Kirat. I think what you highlighted on is that doing these tests are important. If you have a positive result, if you have a positive antigen or antibody test, and if you manage to correlate it with the CT findings that this patient has, and if you made a diagnosis of fibrotic or non-fibrotic HP, removing the person from that hint is often very useful. Vishali, the other side of the coin, often you would get some inciting agent which is available in the individual's home. So be that the air cooler, be that the fungal spores, be that the pigeon droppings, and you have someone with interstitial lung disease with a pattern which is not classic of chronic HP. What do you do in that scenario? So the audience asks, if you have someone who's got interstitial lung disease on CT, not the classic chronic HP picture, and you have an inciting substance, right? And change involves something which is dramatic, changing the person's home, doing away with the pet, giving away the birds which are dear to the person. How much do you insist? How do you actually go about establishing a causal relationship between the inciting antigen and the disease process in these patients?
An extremely difficult question, sir, with a difficult answer actually. Because one is that, if you meaning to say that there's an ILD which is not like an HP, and still there you see some
CT.
kind of
Correct.
or a CTD ILD, and you still see an inciting agent. But HP, there are multiple papers which shown that even CTD patients can have HP, and otherwise. So I think in our rifle way, we have to, if we see an inciting agent, we try our best to convince the patient that they could do away with it. Even if you say that it's going to be a major kind of a change. So like Kira just said, changing her workplace, no, but air coolers and pets is something which we could definitely, and the pigeon exposure, which is something I think I advise anyways to all my patients with lung disease, because we do not know what is the genetic predisposition and what is going to be the environmental, the phenotype and which patient is going to react. So as I think as a pulmonologist, we will say that though at the back of our mind, we also know that there are papers which show that despite removing the inciting agent, some people do progress. But I think, it makes sense that we remove the inciting agent wherever possible and not think about, okay, this person is anyways going to progress, because that is an important point in patients of HP also, and in a patient where the zone is not clear, whether this is a CTD, ILD or an ILD. Whether this could be a factor which can be related to his exacerbations later on. So I would err on the side of, being a little unfriendly with the patient and trying to get him off the inciting agent.
Yeah. So Vishali, the only thing I wouldn't agree with you is that you're being patient unfriendly. You're actually being patient friendly. And I agree with your message. I think the important thing here is not to presume that the pattern is not chronic HP and hence say, you've got CTD, ILD, you cannot have chronic HP, let's keep the pet. But make sure that you try and persuade the agent to take away the inciting agent. However, antigen removal, inciting agent removal might not be the only treatment, which brings me to my next question. I'll come to Arjun. So we've got about 5 minutes, Arjun, so quick answers, and then we'll take a few questions from the question box. Treatment. How do you initiate treatment, and what are the categories? We heard Dr. Murli Mohan go into great detail about the treatment, but some strong carry-home messages from your side about treatment categories and what you use in your clinical practice. Arjun.
Basically, that depends on whether it's fibrotic or a non-fibrotic HP. Non-fibrotic HP, not much of symptoms. Basically, the most important thing is avoidance. But if the patient is symptomatic, like most of them have intractable cough or something like that, then these patients need to be put on steroids on a tapering dose and to be stopped over a period of 6 weeks. Chronic HP or fibrotic HP, inevitably they come to us because they are symptomatic and they need to be started on steroids. I usually start at 0.5 milligram per kilogram body weight of steroids, and then slowly taper it over a period of 6 to 8 weeks. there are a good percentage of patients whom, when you step down the steroid beyond a certain point, they start to develop recurrence of symptoms. So then the option comes up whether going back to the higher dose or add a steroid sparing agent like azathioprine or MMF. And then, of course, with the confidence that the inbuilt study has given us, if the patient shows evidence of progressive fibrosis, then I usually use nintedanib also in my practice.
Wonderful, Arjun. So clear messages, non-fibrotic. They're, of course, coming to you, like Kirat said a little while ago, because they are symptomatic. If they've got enough symptoms, removal of the antigen from the inciting agent along with steroids. The steroid sparing comes in when the steroid dose, when you lower the steroid dose, you have recurrent symptoms. And the fibrotic part, you would probably have an overlap between non-fibrotic and fibrotic. And hence the antifibrotic comes in along with the steroid and maybe the immunomodulator, the immunosuppressive agent. Let me come to you, Anant, about the prognosis of patients with chronic HP. Again, we heard Dr. Murali Mohan speak about factors which include mortality, but important points that you want our audience to keep in their head when they see someone and prognosticate at a clinic consultation in someone maybe with a fibrotic HP.
Okay, so again, quickly, just without elaborating too much, I think some quick points that one must keep in mind for a patient who are having likely to have worse prognosis are, say, a longer duration of the exposure to the inciting agent. One, where we know that there is an inciting agent, first of all, there. Older age, that is one. Somebody who already has pre-existing either some lung problem or declining lung function, or who's having severe symptoms. These are the people who are kind of more likely to progress. Apart from that, of course, then there will be after that, once you follow them up, then development of, say, pulmonary hypertension and all these things. And then there are a couple of predictive scales also, gender, age, PFT. So there is a gap score. ILD gap score is there, in which there is a gender, age, and PFT, these three which I mentioned. So these are the three simple ones which on an OPD basis can help us kind of prognosticate. Then, of course, there are many other things which come later during the course of the illness.
Sure. Wonderful. So there's a lot of questions in the question box. I'll take some of them. So I have Dr. Sanjeev Khunte asking about the duration of the steroid, the immunomodulator, and the antifibrotic. So I'll take that question to you, Anant. So how long do you prescribe it for? I take the antifibrotic is for long term, but what about the steroid and the immunomodulator? How long would you prescribe that for?
So for steroids, if it is a relatively acute thing and the patient is symptomatic, we start off with 0.5 milligram, as Dr. Arjun said, 0.5 milligram per kg body weight, first for at least 2 weeks, maybe 2 to 3 weeks, then taper it relatively rapidly over the next 2 to 3 weeks and try to finish it off by around 2 months or so. So as soon as possible. Of course, it is flexible, maybe go up to 12 weeks or 3 months. In more subacute or chronic or more severely symptomatic, we give it for slightly longer. Same dose we start off. We give it for 3 to 4 weeks. Start tapering, come to a maintenance of 10 milligram per kg, 10 milligram per day, say in about 3 months, 2 months or 3 months, and give it for further 2 to 3 months. So total at the most maximum of up to 6 months. So this probably would be the general guideline. If he does not respond or relapses during the tapering part, either you increase the steroid back again, or you do not increase it, but you add a second agent, which may be MMF or azathioprine, as was already discussed. So I think 6 months probably should be the maximum by and large in most cases. Apart from that, of course, removal of the antigen.
Sure. No, absolutely. And I think Dr. Ajay Lanjevar asked question on the same lines. I think Anant, you've answered both of them. There's this question about rituximab. So let me ask Arjun quickly. I mean, I have to confess, I haven't ever used rituximab in my patients with chronic HP. Any experience, anything that you've read in the literature or done yourself in use of rituximab in patients with chronic HP? That's Dr. Vishakha Kapadia asking that question.
Raja, no, my experience is nil. I've not used rituximab, but as Dr. Murali Mohan showed in his study, there are some small studies with about 20-30 patients they have studied, which showed that it works well in at least some subgroup of patients. But my experience is nil.
Yeah. So same here. Anyone else in the panel with an experience of rituximab? So my carry home message for you guys is I don't think there's enough evidence in the literature available to use rituximab in patients with chronic HP. So I think even though there's some observational studies that Dr. Murli Mohan spoke about, I wouldn't burn my fingers with rituximab in chronic HP. I'd probably leave it with the MMF and the azathioprine that people have spoken about. A very interesting question. I'll take this to you, Kirat, and maybe to Rushali. Acute HP, which you spoke about, how do you distinguish that from acute asthma is something that Dr. Sujata Sarda has asked. And then maybe Rushali, there's someone else, and I'll tell you the name in a moment, but asks whether doing allergy tests is useful in patients with chronic HP or not, as in identification of the inciting agents. So Kirat, acute asthma, acute HP, how do you distinguish?
Typical features clinically. First, we look for typical clinical features, sir. See, the fact is that whenever someone is having acute exacerbation, we may not be able to do a PFT. Otherwise, obviously, we know we have obstructive pattern in asthma. We have a restrictive pattern when it comes to acute HP. But typical wheezing, typical history, any triggering, maybe patient had URTI and then asthma was triggered. So that typical history and clinical features in asthma on one side, and response to inhalers, quick response to nebulization, quick response. And on the other hand, for HP, sir, the CT picture, the X-ray picture. So clinically and radiologically and response to basic nebulization, we because HP patients, acute HP respond to much higher steroid doses. They don't respond to the general asthma dose. And the question for allergy tests. Someone who's having an acute HP, that is not the time to do an allergy test, one. Second, you need to have a PFT before you do an allergy test. Third, the concentration of the allergens are not standardized in India. So that's a major challenge when it comes to doing allergy tests. And they are not validated for interpretation in HP.
Sure. So I think the first part of the question, I think, Kirat, the bottom line is that they are very different diseases. Then acute HP and acute asthma are very different diseases, even though the triggers are in the environment for both, like we said. The clinical manifestation, the examination, the auscultatory findings are very, very different in both. So I don't think there's actually going to be a confusion, even though I agree with the person who's asked the question that the inciting factor seems similar. So why would the disease be different? Vrushali, what about an allergy test? I mean, that's not something we talk about in patients with HP. Why do we not talk about allergy testing in patients with HP?
So like Kirat just mentioned, allergy testing, I'm not even sure I use in asthma, reason being the standardization of the process. And what do we see the person is allergic? Maybe, it is just like a typical HP panel. So somewhere a person may be exposed and may be developing antibodies, but doesn't really have a hypersensitivity pneumonitis presentation otherwise. So I am a little, over the allergy panel is something, that's the reason I do not really do it even in asthma, and I leave it to the allergic specialists really. That there are a lot of a lot of gray areas, that where you try to tell them to avoid a multiple host of allergens, and this is not actually what the patient may be allergic to, or maybe that is the reason the asthma. So I am not sure about doing an allergy panel in a suspected HP individuals. If that is a question you ask me, especially in HP, I wouldn't venture in that area.
No, I agree with you. I don't think the physiology of the disease is such that you would actually be looking for the inciting antibody in the blood rather than doing an allergy skin test in these individuals like you would do in patients with asthma. Rarely, like you said. But I don't think it is something that's validated ever in patients with HP across the board, as skin allergy testing. There's a question from Dr. Shoibal Ghosh who talks about steroid use in a diabetic. I think it's the same with all interstitial lung diseases. If the steroid is indicated, if there's an inflammatory component, you will have to use it. And you have to make sure that your friendly diabetologic colleague makes sure that the sugars are under control while you're giving these patients the steroids. I think that's the carry home message for any interstitial lung disease, not just chronic HP. We need to wrap up now. I think we are well past the time when we were supposed to finish. I'm very, very pleased that we have more than 1,600 logins with us even at this moment. So as we finish, let's start off with Kirat, the way we started the questions. I want you to give me one take-home message for our audience, Kirat. that they need to remember when in their clinic tomorrow they see a suspected patients with HP? Kirat.
X-ray may be normal. Always get a CT chest. Take detailed history. Ask for inciting agents. Try to get have the questionnaire handy.
Okay, so questionnaire important. Remember the questionnaire, guys. That's an important factor. We often don't do that because we are in a hurry. Make sure there is a questionnaire that you try and ask, inquire, or your colleague does it for you. Roshali.
One important message is that when all those patients who come with you to you with a radiology which is showing a chronic or a UIP kind of a pattern, I would not err on the side of relegating them to the antifibrotics. I will look out for HP in that small subset of individuals who might benefit with the anti-inflammatory drugs.
Yeah, so important point, Vishali. Remember this gray zone between IPF and chronic HP, the fact that you can diagnose one or the other by mistake, and the fact that these diseases are treated differently, the prognosis is different, and hence making this distinction is very, very important. So valid point, Vishali. Arjun.
I would actually highlight the point of having to get a good quality CT scan done, and both an inspiratory and expiratory pair. It's very, very important when you speak about HP. And of course, the important signs that Bhavin had mentioned, especially the triple density sign and the hexagonal pattern, which is very, very useful to distinguish chronic HP from chronic fibrotic NSIP and fibrotic sarcoma.
Sure. So Arjun, important point. I think you also highlighted the fact that the HRCT features of chronic HP have increasingly been recognized, and the fact that now most cases can actually be diagnosed on good history, along with the questionnaire we spoke about, along with the CT signs that you talked about, rather than having to resort to doing histology in these patients. Anand.
I think I would actually like to just emphasize the very first step that has to be done, like you said, and everybody has emphasized, is the history. So more and more detailed history, longer communication, a detailed occupational history is mandatory, environmental history is mandatory, and history regarding whatever is there in their house is important. So all these things have to be taken in great detail. So awareness about this entity, I think, is first and foremost, which has to be there. And then once you diagnose, after everything, again go back and tell them why they have to move away from this antigen or whatever we have identified. So I think it's a two-way process, one before diagnosis and one after diagnosis.
Wonderful. So yeah,
I'll just add to Dr. Anand this, that the occupational, the environment and recreational, we had this patient, we took it on the table and we were just talking, then what are the hobbies? And the guy says, I feed around 1,500 pigeons every day. We cancelled everything, the biopsy and things. And so a recreational history is as important.
So history, very important. Do ask for a good history in anyone who comes to you with suspected interstitial lung disease confirmed on a CT. So very valid points. So thank you, everyone. I need to thank the audience first who've been logged in with us for the past 2 hours. I hope you enjoyed the discussion. My heartfelt thanks to Dr. Bhavin Jhankaria and Dr. Murli Mohan for joining us and enlightening us with the lectures. I thought both of them were brilliant in the way they spoke about the entire spectrum of hypersensitivity pneumonitis. Ananta, you are a governing body member for the ICS, so thank you for being there with us to the meeting and enlightening us. Arjun, you're always there for our meetings, so thank you very much for highlighting important points. And of course, Kirat and Vrushali, thank you, ladies. Wonderful points that you brought across. And I think hopefully we have a lot of important points that have been highlighted for the audience today, which you can take forward in your clinical practice. A big thank you to CIPLA for having supported us in this endeavor like they normally do in lots and lots of our meetings. And last but not the least, the entire governing body of the Indian Chest Society, Dr. Amita Nene, the chair, thank you for putting us on this platform and allowing us to do this meeting today. Thank you very much and good night, guys. Thank you.
Thank you very much. Good night.